My name is Sarah. I'm a radiology resident at UI Health in Chicago, Illinois, and in this presentation I will walk you through how to read a screening mammogram. A screening mammogram consists of standard views including a right craniocaudal view, a right mediolateral oblique view, a left craniocaudal view, and a left mediolateral oblique view. Additional views may be obtained if needed, included but not limited to an extended CCL view, which is a type of exaggerated CC view particularly good for imaging the lateral aspect of the breast, and a cleavage view, which images the posterior medial portion of both breasts. Screening mammograms include 2D images or a combination of 2D and 3D images. 2D images can be obtained digitally or they can be obtained synthetically, meaning the 2D images are generated from a 3D tomosynthesis scan. Currently at UI Health, all of our screening mammograms are done with tomosynthesis. Some of the mammographic abnormalities that we look for on screening mammograms include masses, asymmetries, calcifications, architectural distortion, lymphadenopathy, skin thickening, and post-surgical changes. When beginning to read a screener, it is important to make sure the exam is technically adequate. There should be no motion or artifacts, there should be adequate compression, the nipple should be in profile on all views, and ideally there should be some fat posterior to the parenchyma on both views. Specifically on the CC view, the posterior nipple line, which is the distance from the subareolar region to the pectoralis major muscle on the MLO view, and the subareolar region to the film edge on the CC view, should be within 1 centimeter of each other. There should also be adequate coverage of the medial and lateral breast. Specifically on the MLO view, the inframammary fold should be open, the pectoralis muscle should extend inferiorly to the level of the nipple, and the pectoralis muscle should have a convex border outward toward the nipple. If the study is not technically adequate, it should be given a BI-RAD 0 for technical recall. There are 4 descriptors for breast density in the 5th edition of BI-RADS, which are A, almost entirely fatty, B, scattered areas of fibroglandular density, C, heterogeneously dense, which may obscure small masses, and D, extremely dense, which lowers the sensitivity of mammography. For heterogeneously dense and extremely dense breasts, supplemental breast ultrasound is often recommended in addition to annual screening mammography. Breast density is usually determined subjectively by the person reading the exam. However, the software used by most institutions does assess breast density and will grade it A through D. Comparison with prior studies is very important, and the more priors the better. You should compare to at least 2 years back if available. If a patient has priors from an outside hospital, they should be requested. Now I'm going to take you through the workflow of a standard hanging protocol and a helpful search pattern. Having a good hanging protocol for screening mammograms is important, and you can personalize it to your preferences. Usually the current exam will be on the bottom and the old exams will be on top, with the ability to scroll through multiple prior exams if they are available. Starting with the bilateral CC evaluation. I first scan through the entire right breast. Then I look at the lateral third, the middle third, and the medial third. I do the same thing on the left side by scanning through the entire left breast, then dividing it into the lateral third, middle third, and medial third. I then compare each third side to side. If at any point I see an abnormality, I can zoom in or scroll through the tomosynthesis images. On the CC view, make sure to thoroughly evaluate the nipple and subareolar region, the medial breast, and the lateral breast, which is where the majority of breast cancers occur. Moving on to the bilateral MLO evaluation. I first scan through the entire right breast. Then I look at the posterior third, the middle third, and the anterior third. I do the same thing on the left side by scanning through the entire left breast, then dividing it into thirds again. I then compare each third side by side. And again, if I see an abnormality at any point, I will zoom in or scroll through the tomosynthesis images. On the MLO view, make sure to thoroughly evaluate the nipple and subareolar region, the axilla, the retroglandular fat, and the edge of the interface between the glandular tissue and fat, which is where the majority of breast cancers occur. I then look at zoomed in images of each third on the CC view. Here is the lateral third, the middle third, and the medial third. These zoomed-in images are particularly helpful for looking for calcifications. And again, if you see an abnormality, you can zoom in further or scroll through the tomosynthesis images. Then I look at the zoomed-in images of each third on the MLO view. Here is the upper third, the middle third, and the lower third. Next, I will look through the tomosynthesis images for the right CC view. These are very helpful for looking at masses, asymmetries, and architectural distortion. Tomosynthesis is also very helpful in women with dense breasts because you can see through overlapping layers of tissue. Next, I will look through the tomosynthesis images for the right MLO view. Then I will compare the current study to prior studies. If you see a mammographic abnormality, always make sure to check if it was there before. Comparison to prior exams improves the accuracy of cancer detection by identifying changes in breast tissue over time, which can significantly reduce the recall rate and false positive results, and it can also increase the specificity of a screening mammogram. Finally, you can click through the computer-aided detection markers and you can click them on and off and double-check any areas that were marked. Now you're ready to make your assessment. Remember that screening mammograms can only be given by RADS 0, 1, or 2. To summarize, here is a list of all the steps I went through. Find a workflow that is best for you and stick to it. Thank you for your time.